To Tuesday evening academic sessions from Yashoda Group of Organizations and the Department of Critical Care Medicine. We try to bring some interesting lateral thinking topics which are maybe a curiosity for many clinicians in and around us. So today we thought bringing some lateral thinking to our regular intensive care medicine. The reason for this topic, the outreach beyond ICU walls by a critical care consultant or an intensivist is the last 6 months of real-time assessment, real-time results, real-time game changer by the Department of Critical Care Medicine in our organization. So we felt the inception of intensive care unit in the years of 80s, 70s, by none other than Dr. Manimala Rao in the city of Hyderabad. So we felt to bring her intensive care unit. So thank you to being a part of this, ma'am. We welcome you, Dr. Manimala Rao, the professor, head of the department of Nizam's Institute. A decade and now being a
there's a lot of disconnection happening, sir.
That's because of the rain.
So to bring us a brief overview, I request Dr. Work on in the field of outreach of critical care medicine over the last 6 months and put a lot of hard work and sweat into it, bringing the changes. So he is our senior consultant in critical care medicine in Yashoda, Secunderabad. So over to you, Dr. Monica Soni, in bringing that over.
Thank you so much, sir, for the kind words. And welcome, Manimala Rao, madam, on this delightful talk to have. Thank you, ma'am. So today, the topic being the critical care outreach team. So we all have been aware of the critical care being given inside the 4 walls of the ICU. But there's a lot of things and changes happening beyond the 4 walls. And this critical care outreach is...
Can we do it full screen?
Okay. Is it okay, sir?
Yeah.
Okay.
Yes.
So it's a small attempt from the hospital, Yashoda Hospital, Secunderabad, to reach out to all the hospitals there and to see what we do have to offer beyond the 4 walls of the ICU. So the term critical care outreach is used to define the process of extending critical care services beyond the hallowed and sacrosanct walls of the ICU by extending the critical care to sick patients outside of critical care boundaries like wards and non-ICU areas, and thus preventing morbidity and mortality. And this also is to prevent acute deterioration and provide timely transfer to appropriate critical care facility. And other than that, once the patient gets better in the ICU, to support the discharge from the ICU to the step-down areas, high dependency areas, which has improved the mortality outcome with the same degree of the critical care along with the financial ease on the patient. Now, what constitutes this critical care outreach team? The evolution I'll discuss in later slides, but what our hospital is doing is we have something known as MedCall team, which is Medical Emergency Team. This team comprises of critical care consultant, critical care registrar, respiratory therapist, and critical care nurses. And the 2 factors which constitute MedCall is the early identification and the intervention, which is prophylactic or therapeutic in the form of the help of news scores. So this is actually what was happening some time ago when we did not know what is happening to the patients inside the wards. But with the advent of new scores, which is modified early warning score, we have a nice, decent systems of managing all the 5 parameters. And these parameters range from temperature, the hypotension, systolic, diastolic blood pressure, temperature, tachycardia, bradycardia, and level of responsiveness. So as depending upon the patient's condition, which is the best form in the way of with the score is 0 to 1. And if it further deteriorates from 3 to 4 to 7, like this graph that this form shows you, the patient has got a score of 8. And at this time, when the score is more than 7, the Muse call team is summoned. And then appropriate action is taken depending upon the patient's condition. Either they can be left in the ward or they can be shifted to the higher facility like HDU or ICU. So this is the form which we have. When my team goes to the ward side, this is a medical emergency team form, and the date of the call, the name of registrar attending the call, the time of the med call reaching the ward side is really important. They have to reach within 5 minutes, and the time taken to stabilize the patient, time of return. And these are various conditions or indications when the med call, how the med call happened, like tachycardia, bradycardia, hypotension, tachypnea, bradypnea, oliguria, hypoxia, and various other reasons, including seizures, and the ward at which the event happened. And this is the intervention done by my critical care, the med call team. It could be depending upon the conditions. And depending upon the timely intervention, whether the registrar decides to take the patient to the ICU or to keep the patient in the ward itself. So this ongoing process of Muse, med call, it's a very buttressed by a lot of things, which are important. One is the knowledge dissemination among sisters, the support and coordination among all the sisters, staff nurses, my registrars, and frequent surveillance by the critical care team and by the senior sisters themselves, extensive training assessment, and the least but not the, least important of all, cohesive interaction between the sisters, nurse managers, which is being overseen by the critical care team ourselves. And how do we do this? It's on-spot training, daily ward rounds, interacting with sisters, staff nurses, and daily review of med calls and code blues. So I would say that journey so far has been really promising, because as we all know, for the past 2 years, all the hospital services have been bearing the brunt of COVID pandemic. And this likely there was care of non-COVID patients was affected because the major chunk of hospitalized patients was all COVID patients. And as with the other hospitals, there was a drop in non-COVID admissions in 2021. And because of these conditions and wearing the PPEs, the ventilators, the barrier nursing, a lot of things happened. So the adherence to code blue and med calls got a bit diluted. So as gradually the COVID weaned off, the occupancy increased, the med calls and code blue protocols was also reinforced. So the 3 main structures in our hospital being the staff managers, which are nurses, the DMOs, and night in charges, they were thoroughly sensitized to accurately record the med call, because many a times with the lapse of the med call being recorded, there have been instances when med calls have been converted to code blues. So what happened? The first analysis of med call was done by me in 2019. So that was month April, May, where we had almost 5 to 10 calls, followed by 10 calls in June, July. And by August, September, we had almost 13 calls. This was in 2019, just a month ago couple of months before COVID. Then as studies was being done, this was mid-COVID when we were having equal number of COVID patients as well as non-COVID patients, mid-July, mid-21, where the med call was 10 in month of July, and the calls increased to 20 in August and around 17 in September. At the same time, what happened to code blues? The code blues in July was 6 number of calls. In August was again 6. And in month of September, it was between 7 and 8. So as we were nearing 21 and coming to 22, another set of analysis were done for the last 3 months. Med calls in November 21 to Jan 22. The number of med calls in the month of November was 8. December, it was 8. January, 7. While the code blues, in September, it was around 17. Month of October was 10. Code blues in November was 15, same in December 15, and slightly got down to around 8 in January. So this time period between November 21 to Jan 22, there was increase in number of code blues, probably due to ongoing COVID pandemic, decreasing number of med calls because the team was going and the patients were really sick, so the code blue was called, and which is still okay for a hospital like us, which is 800 bedded, and during that too, during COVID pandemic. So what we had to do, the rise of code blues, something had to be done out of the box. And how? So we still had to bring down the number of code blues. So we followed, what did we do? We followed a very robust system of surveillance, extensive training, assessment, and rigorously sensitizing the importance of MUs and med calls to the DMOs, nurses, by none other than the critical care team. And then came the game changer. After a hard work of months from February onwards, extensive training, surveillance, taking the induction classes, going daily rounds in spite of a busy schedule of critical care to the patients. We had the code blues. If you look at the month of March, there were almost 12 code blues, and we had successful 6 discharges with no deficits. In the month of April, we had total 9 code blues, where we had 4 discharges with no deficits. And month of May, the last month, which heartwarmingly, we had 3 code blues with 1 discharge. And this ongoing month till now, we've had only 1 code blues, and that too lady was a CA Thyroid patient with AF, and she too has been discharged safely. So 1 by 1 discharge month of June. So, but at the expense of what? The med calls. So if you look at it from March to June this year, we had med calls, the number was 12 in March, which steeply rose to 22 in April, 33 in May, and it's still ongoing. As of now, to date, it's 33 in month of June, with a steadily rising number of med calls. So clearly we are having a winning edge, courtesy our all thank the persevering efforts and the supports we're getting from all the departments. So that was about our hospital, the local setup, how it all initiated. So what exactly happened around the world? This was first initiated by National Health Services in UK. And the components, this is way back in 1990s. And the components were, because NHS is basically controlled by government setup. Unlike India, we have got major players in forms of private setup. NHS till to date also is completely owned by the government setup. So they are actually cash strapped. So they have to be very careful in how they allocate their funds. So the major players being ICU, the higher education providers, the community service, and other stakeholders. And all of them, they are all working towards to meet the needs of critically ill patients, both in the ICUs and out of the ICUs. This is data derived from the UK NHS. So the motive is that they have to encourage our the senior doctors, the nurses, the managers. So all these 3 important factors in any hospital, they implement the proposals, they prioritize the development, and they secure appropriate funding, especially in a government setup. And how it all evolved. So it all began with National Patient Access Team Modernization Agency's Critical Care Program of 2002, which actually started Plan, Do, Study, Act as a tool to effect change. And that's how Critical Care Outreach Team, which first started from the UK itself, came into existence. So in various countries, it's known by various synonyms, MET, which is Medical Emergency Team in Australia and India as well, Patient at Risk Team in Canada, and Rapid Response Team in US. And all the common goal is to identify patient at risk by appropriate new scope. So what actually triggered the formation of Rapid Response Team? So this is the committee, which was National Confidential Inquiry into Perioperative Deaths in 1993. This report found that 2/3 of the post-op patients died in the ward after apparently being stabilized in the ICU. But why they died? Because of the cardiorespiratory failure. And why did that happen? because there were substantial shortfalls in the critical care services in the outreach, in the non-ICU areas, probably H2 or in the wards. So similar issues faced in Harvard Medical Practice of 1991. So that was the evolution and how it all began the world over. So in our hospital also, it's a continuous ongoing process, and we have a lot of difficulties, we have a lot of pitfalls. And so what we found out was that we do have inexperienced staff, but they are not to be solely blamed. We do have untrained DMOs, but we do not have to blame them either. And then our wards are having a mix of cases, which are both sick and old cases. And I would say, because not just my hospital, there are other hospitals which are facing the attrition of the nurses and DMOs. We train them, they become better, then they fly off to greener pastures. And DMOs, we train them, they clear the need, and then they go and join the PG courses. But then we have to bear this brunt and see what is to be done. So other thing is, my team, just like any other critical team, yes, we have been burdened because we have a choco block running ICUs. We have to take the care of the patient of the ICU in the first place. And then we have the code blues call running from pillar to post to go and attend the calls. And then our team has to go and attend to the bed calls also. So I think the management, they should think that critical care outreach team is not a substitute for insufficient intensive and high dependency beds. It's not a substitute for inadequate ward staffing, inexperienced trainees, lack of senior medical supervisors, inappropriate skill mix. And neither should the outreach team assume the clinical responsibilities for the care of all the patient at risk of critical illness from other department. But having said this, we still have the responsibility to bear and to take care of the patient at risk in the wards. So how do I do it? Apart from doing basic rounds and looking after my critical care patients, I do pinch out my time and I do the daily review of med calls and code blues, which have happened the day prior, the night prior. I check the MU score before the med call. I would go back on the slide of the MU score, which is very interesting. So if you see this slide, this has got the MU score, and this has got the scoring system as well. So this patient got a MU score, the med call summoned, by the virtue of the score being 8. So all this while, every fourth hourly, the score was 0, 0, 1, 2. And when the score became 8, probably because of the temperature, which is 102, or the heart rate, this med call is summoned. So like this, I go and check what exactly was the cause of the med call and what would we do. So once the med call of 8 is achieved, the sisters or the DMOs, and they summon the med call, and then checking the MUs before the code blue. As I discussed before, 1 or 2 times we have faced a grim situation where the patient was sick immediately and the MU score had to be converted to code blue. So why the code blue happened, this also has got a lot of factors, and this I go into details and find the root cause analysis. And if there was an inaction or action before the code blue, or when the acute detention of the patient happened. At the same time, I do not wait for DMOs to tackle them the day after. If they're there, I make them wait after duty and sensitize them. Why didn't they call the med call? What was the problem? Was there any technical issue where they could not call the med call as to why the med call was missed? And then I do my daily rounds. I've got a team of my another colleague, Mr. Dr. Convenor is there. So we take rounds of each floor every second or third day, and we have got this plan chalked out. So we keep in mind that who are the underperformers, performers who are doing well, which floors need a lot of, like in my hospital, 8th floor, which is onco floor, has got of med calls coming from there. So why is it happening there? So this way we have an idea about all the floors and their functioning regarding the capability of handling a code blue and how well they're prepared for a med call. So what next? Very important, as other protocols, mock drills for med calls and code blues bi-monthly. Interacting with DMOs and nurses on one-to-one basis. Believe me, I know all my DMOs by virtue of assessment, as Dr. Venkat has mentioned, and one-to-one basis. And I do know who the slow performers are, but yes, we are really struggling hard to make them better. And those who are doing good, incentivizing them and make them the trainees, the trainers. Reassessing them, encouraging them by showing them the promising results of this month, and induction classes for the newly joined DMO staff nurses, and the assessment classes for those people who had not done well. So the bottom line is training, training, and more training is the cornerstone of the improvement. One word about the DOSI. During the pandemic time, there was a startup in Bangalore, the Turtle startup. So with the funding from Kavach program, which was augmenting our war against the COVID-19 along with the government support, this Indian startup developed early warning score alert mechanism for at-risk patients from a distance. So what happens? So remote patient monitoring is becoming a way of life for hospitals without having to visit patient manually and deliver enhanced level of care, quality care through pandemic and beyond. So I just go through what it entails. It has industrial grade contactless sensors, a communication cord. It's a cloud-based learning, basically, a cloud-based patient monitoring tool with artificial intelligence power, triaging the system, which captures real-time body vitals and provide round-the-clock monitoring of the patient and integrates the devices like saturation monitors, ECG, temperature, and other parameters. So finally, coming to what should this talk take home to? So I would want all my colleagues and doctors out there who are listening to this talk to encourage your hospital and other hospitals to formulate your own critical care outreach team, to initiate comprehensive critical care outreach to those patients who are at risk in non-ICU zones. And thus, see, what are we here for? We have to have a good quality indicator and nothing but a code blue. So I am proud to say that I'm a part of intervention of an organization where the code blues have really come down to 1 this month by early intervention, enhancing patient safety, improving quality indicators of the healthcare system, and not last but the least, extensively training assessment program of DMOs, nurses, who are the first point of contact with the patient. And thus the aim of Yashoda Hospital is in the coming months to have the number to 0, if not possible, but we'll try it at level best. Thank you.
Yeah, thank you, Dr. Monica, for that excellent. This is not a talk, but her experience, and it's truly, I truly meant that when I say this is an experience of her. Dr. Monica, there were some questions in the chat box before I go to Manimala ma'am. Related to few of friends wanted to know what kind of framed guidelines you wanted to give to them, that the roadmap you have already spoken about, but just to re-summarize that.
All right.
Some questions related.
Yeah. So what I have seen is like when I was going to data in what is happening in India, most of this critical care team work still is being done by anesthetists and anesthesiologists. So if in your hospital, if it is critical care team or whether it is the anesthesia team. So you have to have first who are going to attend the med calls, number 1. Number 2, when who are you going to reach to the wards and how trained are the people there? They should be having an idea of the early warning score. Some time ago, the sister just wrote BP, pulse, temperature, that's about it. Whether the BP was 80/70, whether the temperature was 104, whether the pulse was 62, nobody really bothered till the patient became so bad as to call a code blue. So if you're having to start this program in your hospital, you have to clearly define in your hospital what are the early warning score signs. If, I mean, Dr. Venkat, if I'm the right path?
Yeah. So what she was actually sounding is system to activate something, and to get that clue, there is a scoring system. Everybody can have their own way. MIOS is universally accepted, that is modified early warning sign. And once that score is known to your resident DMOs who are at the patient side or the nurse who is at the patient side, they can activate that. Otherwise, first they have to understand and know.
True.
Team on board. And this med team should be well-trained, well-equipped to actually face that. And there has to be administrative and your departmental support to have a flow. So I think that's the overview she gave. And the core idea is to prevent a code blue, prevent a cardiac arrest in the in-hospital setup. So that's where we actually came. See, when we analyze the code blue outcomes, see, you may actually achieve a ROS but what happens to the cerebral system? Where is the patient had any deficit, has recovered? So when we saw more than 60-70% patients who actually had a code blue in the ward, still got a deficit at the point of discharge. So that made us to think, should we prevent all of them? So even though you have a very robust code blue system, you still have a chance that these patients may land up in some form of hypoxic arrest, and that may leave the family, the patient, for a lifelong disabled. So, ma'am, Manimala ma'am, you have been the cornerstone pillar for the intensive care medicine in the city of Hyderabad. And we heard many of your struggles, many of your initial startup stories when you actually initiated your first intensive care unit 20-30 years back in Nizam's Institute of Medical Sciences. And now we are walking beyond that in those guidances and umbrellas to a state where we are now able to save patients' life. I could actually proudly say the 10 lives or 12 lives which are saved in this month in a hospital which actually caters around 4,000 admissions, 150 ICU beds, with so many sift out, so many procedures, so 80 to 90 surgeries, one code blue. That's something which actually thrilled me to bring this discussion, to bring a change in the Department of Critical Care. What is your take in that, ma'am?
Well, can you hear me now?
Yes, ma'am.
Yes, ma'am.
Yes. So the thing is that everything starts with nothing. That is how life is. So we will have to start and go ahead. And in the beginning, if you all remember, many of you would be anesthesiologists who have taken to critical care because you thought it was a good profession to sort of practice of the critically ill patients. That's how I thought. And there is more communication and more work can be done outside the operating room. This is what. So at that time, the dictum or the thing was that let us go out of the four walls of the operating room. That was the time when we all went out with either with the pain, with emergency medicine, with critical care, and so many other palliative care, so many other areas we have sort of tried to do it. And I liked critical care because I'll tell you why I like critical care. Because there was no critical care in the 60s and 70s. But when I went in the late 60s to All India Institute, there was a critical care. So that has made me, though I didn't see much critical care in UK, but I've seen resuscitation in UK. But it was not there in All India Institute, which is one of the premier institutes in our country. So everything starts. So when I went there, they called me for resuscitation once in the casualty, but there was nothing. So I have built up my own resuscitation guidelines being a student. Okay. So I used to carry everything wherever they called me. So that was the starting for resuscitation for me. And the critical care, what I have learned, I always dreamed I should have developed that critical care wherever I go. Because for me, I have worked always in cardiac anesthesia with the cardiac surgeon. So I always had a post-operative critical care with ventilators. So we used to literally work at least a day or two on ventilators with these patients sometimes. So that's how. And we started with a single bed in NIMS, single bed. There was nothing when I went there. So on that bed, we had two ventilators. I don't know whether you all saw the cake ventilators, bag and bottle type. Okay. Sometimes they used to go up and stay there, not come down. Okay, so we used to call it a launching pad. If I have taken 10 patients, if I have saved even 5, then I'm happy that I have saved 5. Otherwise, they would have died. But slowly we developed over a period of time. It became 6, it became 12. And even when I came to Yashoda, there was not much of a critical care. And even the code blue was started there by me, and even the med was started. But, the youngsters have to take it much more ahead and then see. It is such a good thing that you have done a survey. So that is how you are much better. I always used to do. And if I'm presenting anything, it is my own work or an observational study or something which you have to present. So that is just not something which you will tell from a, this person has written, this person has written, this is evidence, this evidence doesn't come. So what is our evidence in our own difficult areas? So this is what I think, and I really congratulate Monica and you and, pushing this, because it is very important that we have to go out to prevent such things. Nobody has got a better mind to help out in these areas. So many times, even in high dependency areas, people who are not trained very well are. But in that area, you require people who are also well trained. And nurse education, paramedical education, if you are taking that, now even here, I do the same thing. Day after, I'm going to talk what is really professionalism for a nurse. So in that way, if you can train them from the very beginning, that is when they are in the colleges. I'm catching the students in the college now. So this is what we all have to do to improve the thing. And these things are going to improve provided you all have the same, you are all on the same page and you all work as a team and you go ahead. Nobody can stop you. This is what I sincerely tell all of you, and be a team and be good to everyone, be polite, nice, and the stress will be also less when you are a team. But one thing, a little caution, is that sometimes they try to put off these, any medical legal issue onto you. So you have to be very clear, even write up and take those things have to be included. And what is the level at which you have gone to see the case? So is it that 8 or was it less? So what is the correct, Monica, what is the ideal time you want them to refer to you? What is the score which you want to refer? That would be a better thing to say. What score?
Ma'am, you very rightly pointed out the resuscitation team or the resuscitation experts. You believe that, ma'am, the emergency team or the intensive care team are really the experts in resuscitation. Either we call it airway skills, either an anesthesiologist, a well-trained critical care specialist, or an emergency clinician. They are the cornerstone of any acute resuscitation, unstable patient resuscitation. So no doubt on that. I think, as you said, ma'am, initially when we spoke about an acutely ill patient needing a resuscitation to stabilize, I think the anesthesiologist or the clinicians who are interested in acute care management, they moved out of the OT to the intensive care, or they parallelly run both the units to manage them.
Yes.
And from there, as you rightly said, the code blue, which you are talking about 20 years or 15 years back, where these all has been initiated from different corporate organizations as a part of their regular quality maintenance and rescuing these sick patients in the wards when they get a cardiac arrest. That was again has been led by the same anesthesiology team, emergency team, and intensivist in these areas, because they probably are the experts in the resuscitation maneuvers. So now coming, what we realized, ma'am, and rescue these arrest patients in the ward or somewhere, the normal time somewhere in our organization varies between some 30 seconds to vary between 4 minutes. So once our code blue team reaches there and they start maybe supporting the existing nursing team there or a resident there. But what we realized, ma'am, even there is an effective code blue happened by our different assessments through CC cameras and also the scribing nurse assessment. We used to see a lot of patients landing up in serious deficits. Some of them remain to be comatose, even though you reach the ROSC, but the patient remained to be with a GCS of E1, maybe M1, and vegetative state with a tracheostomy on with some form of spontaneous breaths or some form of some kind of a ventilator. But they became such a huge kind of a burden with otherwise stabilized organ, but the anoxic brain made not only the patient, but the whole family devastating. The rest of the life is so horrible. So that actually made us to think these 12, 10, 14, whatever, the cardiac arrest which are happening because of acute deterioration or a patient who is worsening over a time. If we can prevent a cardiac event or a cardiac arrest or a respiratory arrest, we realized that should be our aim. So as you said, ma'am, we moved out of OTs to help in acute care setting in resuscitation. Then we went to save at least 20-30% of patients who actually go out walking, but we tend to lose 60-70% of patients to either a vegetative state or they get again arrest. Now we are talking about further preventing them. So do you see this is an evolving critical care which we are crossing one after the other?
Yeah, definitely, Venkat, because everything in life, there is a change. The change comes as we see, whatever has happened over a period of time. When you analyze them, when you see what is the change, then you want to improve on that, whatever is there. That's how we look at it. So most important is, see, when I went to Yashoda Hospital, way back in 2005, after I retired, there were only about, say, 10 beds in Somajgura, not much in both other places, right? So there, we used to have 60 patients, used to be ventilated over a period of 1 year. That was what it is. So they were never putting anybody on ventilator. They were scared. So when I went, by the time I left, it's almost 600, 700 patients we used to ventilate. And even the worst cases used to come. So it is a change which happened in all areas. And the same thing will have to happen as you go out to reach out to people. What do you mean outreach? You're going out of the critical care, but it's a lot of burden on you. You need more specialized people who are going to, work in those areas and take care, because it becomes also a little medical legal issues when we are involved. So you have to have well-trained people who are interested to move forward, like Monica has done all that. So a little proactiveness to do this is what you have to see as a leader.
Rightly pointed out, ma'am. One is medical legal aspect. So what we counterbalance by that is whenever we actually get a med call, when we go to the patient and assess the patient, what we do is we make sure that the primary clinician under whom this patient is admitted is being communicated, either by the resident doctor there or the nursing who is taking care. And one of us, after the assessing the patient, we make sure we speak to them and make the situation aware to them that there is some deterioration, this patient needs to be shifted out. In the meanwhile, the family is taken into the conference. See, these are the dynamics we are considering this patient need to be more vigilantly monitored. Now coming to
acting more as a coordinator to improve this one. So the aspect of medical legal will be much less on you because you are trying your best.
So last 6 months, fortunately, we didn't have any concerns with both the primary teams and the family. And then there comes the problem. Sometimes if my primary team or the family is reluctant to transfer this patient, it do happen. Some families may feel the intensive care unit is a high risk zone. They will not be allowed. Patient sometimes who's a conscious may be reluctant. And sometimes the primaries also has been burdened by the economic burden, which the family sometimes request them. So these all concerns comes. So when we actually express this to the management, these are some of the challenges which we face, then we get a blank, probably a kind of a blank is given or a blank statement given from my organization, which I can actually openly say on a webinar that the patient safety remains the highest layer. So the critical care consultant standing there, if he feels the patient is not safe, there are financial challenges, the primary and the family is at that point of time are not very confident of the financial, you need to shift the patient to a more vigilantly monitored area. And next day morning, when all of us can meet and then discuss, and then we can take a call as the patient wants to continue the services or not. But at that point of time, the patient's priorities need to be addressed. And it is a blank statement given to the Department of Critical Care Medicine, which made our job much easier, so that we shifted all our med call patients to the ICUs, ma'am.
So that is a good change now, because now people have realized that our client is the customer, and we have to be very professional in getting the whole thing done for our customer. So what is it? You have to talk to them and somehow convince them. So in the med calls also, there are some patients could be like an end of life issue or a palliative way. Those things also, they have to be written there when you shift. You don't have to call. I used to tell them, don't call for code. Okay. These are some of the things which are not necessary. So these are certain things we can, as we are going ahead, we will be learning. Every day is a learning day for us till we die.
True.
That's what I think.
True,
okay.
True, ma'am. And it when the oncology patient end of life care,
yeah,
where the nurse by a routine habit has med call, and we make sure that our team reaches there irrespective of what was the prior directives, and the team reaches, reassures that, okay, this patient is in a palliative care, comfort care, end of life care. So the family and the patient has been reassured, and the med team comes back, allowing the patient to stay back there. And sometimes the primary also ascertains us that this patient is for a comfort care. The family, or we don't want the patient to be in a more intensively monitored area or invasive areas.
So we used to do that even in the system, tell them, don't call.
I would like to add one thing here.
Yeah.
Actually, a while ago, I mean, a couple of months before, the primary consultants were really not aware about the concept of MedCall themselves in our own hospital. But so when they saw the results, when we showed them the results of the code blues coming down and MedCalls increasing, so they also kind of have more faith in us now. They say that even if the patient is out in the ward, and there is somebody at the back in form of critical care team, in form of MedCall team, and we're just trying 24/7 service. So my team is then in MC1, they're stationed there. We are just one call far. And as soon as any sign of deterioration, and the sick patient is taken care of. So the primary consultants also have got a lot of faith in our critical care now. I mean, all the more now.
Yeah, that is the main thing, Monica.
Yeah.
We get them with our knowledge and the clinical acumen and our readiness to work anywhere without showing any inclination to shirk work and doing a good job, you will be appreciated anywhere in the world. Okay. So that I will tell you, because even the mightiest people sometimes come down and say, yes, we agree. This is the work which you have done. You show them your work, like what you have shown. That work talks for us. That is what I'm saying. So suppose if I do like ARDS, I have done so many cases. Suppose I have given pressure control. Many people used to tell, why madam pressure control? I said, no, this is what I am going to do. And I showed so much difference. Even if you put on volume, the next day you have to go to pressure in a severe one. So there's no point. So this is what you have to show by doing your work and publishing it. So publish it.
I think Kola got disconnected. There's a minor technical issue.
Technical issue, okay. Anyway,
it's a rain wreaking havoc on the
that is the technology.
Online traffic as well as the offline traffic.
See, that is why clinical acumen at bedside is really good. That is one thing everybody has to learn. So whether you can see from 1 mile away and say whether he's on volume control or pressure control is important.
It's a difference.
You should know.
True.
That is the base which will form you to develop into a big thing. Okay. So that you can develop more skills.
Sir, Dr. Venkat?
Venkat has gone.
Yeah, ma'am. Sorry for the technical difficulty, ma'am. Ma'am, we are now talking about. Yeah, we are now talking about a medical emergency team just to prevent poor blue, ma'am. What is your take of rounds when we actually shift the patient out of the ICU after they make a good recovery or after they make a good recovery in high dependency unit, and they will be transferred to either sometimes step down or sometimes to the room side. These were the sicker patients who have been extubated, who has been recovering. So what is the role of intensive care intensivist making a rounds in these patients? That is
I think it is one of the best. I used to go and see some of the patients who are really sick. They come out with the difficulty and then they're either shifted to the ward or they're shifted to the HDU. But we have to make some time to go and see so that they also understand that we have not just left. So it's a good idea, at least that the person who has taken care in a, continuously, if that person goes and sees, he will get a lot of improvement, and you also feel that. And also run a OP. So in the OP, you will be asking these patients come back after, when you come for your checkup, you please be there. One OP you run. That is important.
So what do you think, ma'am, this post-discharge intensive care patient, the follow-up? You should have a critical care OPD.
Follow-up. See, like we have sick patients can be followed up. Okay? Not every single patient. Because they
patient
just
with tracheostomy, patient with
swallowed some 2 tablets. They were there one day and went away. But that is not. Those are the sicker patients who have been with us for a longer time. I think it is good to follow. I think if you can make an OP for them, you can have it 2 times or 3 times a week to start with. And if your number of patients who are more sicker, you are seeing, you can have it on a particular time in the OP times in the morning. So that will be. But all this will require again more number of people. That is the. So
yeah, ma'am. I got your point, ma'am. I think from the beginning, during the MET team and during this event rounds, you are pointing out we are already overburdened sometimes. We are already burnt out. Sometimes we actually see a huge surge in cases. So how do we actually time management, department management, and our burnout management, exhaust management, exactly the same thing has been appraised to the management that now most of the admin and management team feels the intensive care is one of the core strengthened department which can make a difference in the patient outcome, not just in ICU, but outside also. So as you rightly said, this is a right time where we can also insist on adding the manpower resources so that we will have one spare who can actually add this all values, education, research, and outreach services. So one person. So that's what exactly we did with Dr. Monica. When it happens to be needed, we try to overcover her responsibilities, and she happens to make herself available full time for a couple of months, and then literally she actually took assessment of almost 900 nurses, senior nurse managers, staff nurses, mentors, mentees, DMOs, registrars, and all. And she has actually assessed across all. So that is again a bigger challenge, ma'am. There were also related concerns to outreach e-ICUs, ma'am, reaching critical care to the peripheral setups. Like we know there is always some limitation in the resource limited countries like India, where many of the peripheral intensive care areas or smaller hospitals, even though they have a bed, a infrastructure, a monitor, but always the professionals or personals, critical care personals are always a challenge. So how do you see the critical care role in outreaching these kind of intensive care beds?
EICs. You're saying about EIC?
EICU, yeah.
EICU, ma'am.
Yeah, the other day, I'm very happy to say that I was called for an inauguration of the
Academic room in NIMS.
Academic room, yes, sorry. I didn't get the academic
I'm aware of that, ma'am. You have been...
Yeah. So in that I saw their EICU. There are so many of them, you know, and 1 or 2 people are sitting there and doing. So if you can at least tell them, okay, do this. Now within that 1 golden hour, kindly do this, give this fluid, this much. That is enough. At least they don't come back with multi-organ failure. From there, if we have to come all the way, because we may not have that many number of cases, but you are working there also, you are taking care. But again, the same thing, you have to have more people who can do. Suppose if you have got ICUs with 150 beds, that is the total number in all the 3 areas. Okay. Yeah. So what is the staff, total staff, critical care people?
Ma'am, each 10 to 12 bedded ICU will have 1 consultant, 2 registers.
So that these fellows will be stuck there only, because every day they require to do so many invasive monitoring, look after the patient. Sometimes we'll be having, we have to phone them, we have to do so many procedures we have to do. That is a minimum we are at. Okay, minimum. And somebody in the night again have to cover 24/7, the same number of people. So for that, these extra things, we require more people who are interested in doing this also. There may be some people not very much interested. You have to find out who's, like Monica, she has taken a lot of interest to do all that. So it is an extra amount of work. So those people, you have to even get them to that if somebody is interested.
Yeah, Dr. K.C. Misra, Dr. Kaladar, are you on board? Pawan, can you actually make them panelists so that they can...
One moment, sir, one moment.
Madam, Manimala ma'am.
Yeah.
So coming to this interest, ma'am, I do see there is a little hesitancy in many of the critical care consultants to do this extra work of actively getting involved in these ward rounds for the Met call activations, or in the kind of a post ICU shift out follow-ups. But ma'am, what I realized is if we don't get involved actively and these patients come to us after a cardiac arrest or after they're getting sicker, then the burden again backs to you. Don't you think that's again kind of a fire back to us, ma'am?
Definitely. See, the problem is if you have to do more work, you know, you will get more benefit. People will know you and you can control that unnecessarily code blues and, you know, things. And when they come, as you said, in a vegetative state, it's so disheartening. After we have done everything, patient is shifted. He has gone to the ward and they didn't do a suction and he got, you know, in the tracheostomy and he had a code blue. You feel bad about this, right? This is what this is. So everyone have to think ICU means it's not just here and there. But many people think, well, this is enough. I'm already having so much work. I can't even sit 5 minutes and eat my lunch. That is how they feel in the ICU. But, you know, if you make it in a very excellent protocols and oversee that in that way, whether everybody has done, that is the person who is in charge has to do it. And he has to teach and train. He has to check up because the others are there. They can go or send them.
Okay. Pawan, anybody in?
Oh, no, sir. Both are not responding.
Okay. Monica, any final comments from your side?
So final comment, as sir, you and madam also have stressed that everything said and done, instead of, apart from having a robust critical care department who is catering to all the intensive care needs of the patient in the ICU, we do need to have one person or any person to carry on the activities beyond the walls of the ICU. And it requires a tremendous amount of passion and dedication. And it cannot be done half-heartedly. Number one. Number two, that person must be a people's person because you have to be in touch with your DMOs, with your nurses. And, they require totally different level of interaction. I mean, I speak with you, I do not do with them. So they should be under confidence that yes, there is person, if we do a mistake, we are not going to be, punified for that, but yes, they'll be taken in a good note, will be taught our deficits. And it is a continuous process. It is a daily process. It doesn't stop in daytime, nighttime. So the daily, the counts of the CPRs happening, why it happened, and it's an entire cohesive effort of the consultants who are looking after the ICUs. The registrar should be sensitized, and so it's just not the whole team has to be behind that person. And yes, critical care outreach team has to be another part or the offshoot of the proper critical care team. So we come down on the number of code blues happening in the wards. So
Dr. Monica, don't you think that with the last maybe a half a year or a 6 months period, you have been very actively, aggressively involved? You
yes,
saved more lives with your active intervention outside the ICU than in ICU. You've been so charged and motivated.
In fact, I was telling Dr. Venkat, sir, you have taken me out of 1 month of the critical care. So I actually missed it because I was not doing night duties also. I was just doing my work and day in, day out, talking to the sisters in the OT, in the H2, in the bronchoscopy. Do they know the BLS? Do they know the MUSCO? It was very, at a time, frustrating, but then I felt, but I think it's a great service to the entire hospital community. And it has reaped a rich benefit, I would say, because now I do know where my nurses stand, how do I have to train them, where my DMO stand. So I think it's a very heartwarming thing. And it's more positive thing to do and go ahead forward to it.
And you actually made all your patients outside the ICU also safe.
Yeah.
Dr. Monica. Any take-home messages, ma'am, Manimala ma'am?
The thing is, you see, when you have the strength in your critical care, so you have to keep rotating because I don't think that person will continuously be there in the outreach. So whether they like it or not, once you have made definitely an agenda and a protocol, you shift people. They have to go for about 1 month, 2 months into that medical.
Students also need to learn. Students also need to learn.
Yes, students also. Everybody in that way, if you send, then it's fine. I don't think it will be burdensome or bundle. Okay, we'll come. And they will enjoy. Some will enjoy it. Some may come back and say, okay, I finished enough. Monica enjoyed. I'll enjoy. You will enjoy. So it's all question is how you look at it. You want to. Even today, I don't mind going there and see. Okay, so that is what I am trying to say. If we have the wherewithal, you are good in clinically, you are academically, you are good. You are administratively, you have to be good. As she said, it is very important. When we talk to nurses, if it's a lady, it is much easier for her to do it. Sometimes if you say, okay, keep it there, they get very upset. Okay. I mean, because I work with a lot with the nurses and their training, I can say. So these are some things. Those who are, if you have got more women, try and send them to that. So in that way, it is easier. I'm not saying men are not good. It's not gender biased. I don't care. Okay. But one thing is this little more human they are. So you go and explain to them, no, it's not like that. You do this way. So they don't get impatient. So that is what makes. So you have to pick those people. They may be in men, they may be in. You try to see, put first those people and then slowly train up them. That will give you the best. And ask them for more people. You can't be doing this without more. They will listen to you anyway.
Okay. Thank you, ma'am. Thank you for that wisdom. So I think the reason why we brought has been very, very elaborately explained by both Dr. Manimala Rao and Dr. Monica. We really felt from my heart out that the results which we actually brought to our organization should be replicated everywhere else. The reason is the changes which we saw when a critical care team reaches out of the ICU and tries to safeguard our patients' health. Beyond ICUs, there is miracles happen, and we could save many more lives, and we could avoid code blues. We all know how painful it is when a code blue happens outside the intensive care unit in an otherwise stable patient. So I hope this webinar has put some light onto it. And I think all the clinicians in the critical care department should also think about, but yes, there is also area of overburdening us. So we need to create a space for that and create an add-on manpower. And I think now as a department, we are able to convince the hospital administration and management that this is the department which can bring changes and can make a difference, and it can be a game changer. So we call this this mission as a game changer mission in our organization. So thank you, Manimala ma'am. Thank you, Dr. Monica, in bringing this.
You can always make it a quality indicator.
It is now. It is.
Yeah, it is a quality indicator.
So add to that quality indicator. That's it. I'll also see, now that you have said that, I'll find out from there what they are doing, what is their metric. I don't go into all that. Already enough I take on, but this I will take it and see how many.
Thank you.
Okay.
Thank you. Thank you all the participants. Thank you. Good night. Thank you.
All the best, Monica.
Thank you.
Better work. Okay.